ओके शायद कनेक्ट हो गया है, लेट्स सी। So hi guys, welcome back to a very tiny topic, but it will set the stage for us to learn the renal disorders. So next 2 months we're going to take up the nephrology, and hopefully at the end of next 2 months you should know how to approach different renal disorders and how to diagnose. So today we will set the basic stage for it. We will get the basics sorted so that when we discuss individual diseases, we will not have any confusion. Okay, so we'll learn how to approach a patient having renal disorders. But before we go to the approach, don't you think we should know what are the diseases that the renal system gets affected by? So can you help me list important renal diseases? Imranul, Tawhid, MBBS 8981. Okay, good evening everyone. Good evening guys. So can we make a list of renal disorders that you are familiar with? So I know something called as acute kidney injury. I know something called as chronic kidney disease or CKD, which is also called as end stage renal disease. Okay, then all of you are familiar with something called as post streptococcal glomerulonephritis. Some of you may be familiar with something called as minimal change disease that you study in pediatrics in particular and in pathology in detail. Minimal change disease. Then some of you might be familiar with a term called as focal segmental glomerulosclerosis or FSGS. Some of you may be familiar with a term called as membranous nephropathy. Membranous nephropathy. Then some of you might have heard about something called as membranoproliferative glomerulonephritis or MPGN. Some of you might have heard about rapidly progressing glomerulonephritis or RPGN. Some of you may be familiar with particularly exam focused topics like the Bartter syndrome. Then some of you might have heard about Gitelman syndrome. Some of you might have heard about Fanconi syndrome. Some of you might have heard about something called as Liddle's syndrome. Then Fanconi syndrome. Some of you may be also familiar with a term called as acute tubular necrosis, and few of us might be knowing an entity called as interstitial nephritis. Interstitial nephritis. Now all of these are disorders of the kidney, right? But they are affecting different structures. So at the end of next 2 months, I want you to recognize all these diseases in a patient or in an MCQ based question or your theory paper. Whatever the story is given to you, the story may be from the real patient or from the MCQ or from your theory paper. You should be able to recognize that this question, this patient or this story is talking about MPGN, or this story is talking about membranous nephropathy. This story is talking about Fanconi syndrome. So how will I be able to recognize that? Okay, now can I localize at least some of these diseases as affecting a particular part of the kidney? Like for example, if someone comes to me with ataxia and action tremor, dysdiadochokinesis, nystagmus, can I localize which part of the nervous system is affected in this particular story? The patient presented with ataxia or imbalance, not able to do rapid alternating movements, we call it as dysdiadochokinesis. When I ask him to touch his nose and then touch my finger, I start noticing that as he goes to his finger, his hand starts shaking. As he comes to my finger, his hand starts shaking. What we call as action tremor or intention tremor. So all of these features point towards damage to which structure in the nervous system? Yes, cerebellum. So I can localize that this is a cerebellar problem, right? Similarly, if I get a person, let us say I got right third cranial nerve palsy and left hemiplegia, can I localize where is the site of lesion? This is what we call as typical crossed hemiplegia. Cranial nerve palsy on one side, hemiplegia on the other side. That typically localizes to the brainstem. The problem must be in the brainstem. Here in this story, the third cranial nerve originates from the midbrain. So the problem must be in the midbrain of the brainstem. So it's possible to localize the site of lesion in neurological disorders. Is it possible for us to localize the site of lesion in renal disorders? Well, that is possible. For that, we need to just take a quick look at the anatomy of a structural functional unit of the kidney, which is nephron. So as we know, the nephron is a structural and functional unit, and this nephron contains a glomerulus and the tubules. Tubules will have PCT, loop of Henle, the descending limb, thick ascending limb, distal convoluted tubule, and collecting duct. So tubules and glomerulus together make up for what we call as a nephron. And a nephron receives its blood flow through afferent arteriole, and the blood leaves the glomerulus through the efferent arteriole. So once blood comes into these glomerular capillaries, the hydrostatic pressure in these capillaries facilitates the filtration of fluid into the Bowman space. And this fluid is what we call as glomerular filtrate. And the rate at which this filtration happens is what we call as glomerular filtration rate. So normally, leaving behind large molecular weight substances which cannot be filtered, like the hemoglobin, blood cells, RBCs, WBCs, and large molecular weight proteins, most of the other substances get passed through this glomeruli into the Bowman space, and we call this as glomerular filtrate. So glomerular filtrate contains water, sodium, glucose, amino acids, lipids, and low molecular weight proteins, which we call as Tom Horsfall proteins. So all of that is there in the filtrate. Now out of this filtrate, some things are required for us, some things are waste. So the required thing should be reabsorbed, and then the waste should be excreted out. So there is, after the filtration, there is a process of reabsorbing what the body wants. So what all we reabsorb? Glucose we reabsorb, required amount of sodium we reabsorb, required amount of potassium we might, like unwanted potassium we may excrete. If not, we will not excrete. Then we might have to reabsorb the bicarbonate. We might have to excrete the proton or H plus ions. We might have to reabsorb the chloride. So a lot of reabsorption happens. So tubules are responsible for reabsorption. Different segments are responsible for reabsorption of different substrates. To give you an example, most of the amino acids are reabsorbed in the proximal convoluted tubule. This is where amino acids get reabsorbed. Most of the water, like 80% of water, is reabsorbed in the proximal convoluted tubule. Similarly, most of the glucose is reabsorbed in the proximal convoluted tubule with the help of a transport molecule called as SGLT2, which helps you to reabsorb glucose as well as sodium. That's why it is called a sodium glucose transporter 2. And this is what we generally block when we block using the SGLT2 inhibitors for diabetes, so that we don't reabsorb glucose and we end up losing that glucose in urine, right? Okay. Now, whatever diseases we learned, we can localize which part of this nephron is being targeted by that disease. Okay. So, for example, you come across a term called as glomerulonephritis. They are predominantly diseases affecting the glomeruli. So, one set of disorders are affecting glomeruli. Second set of disorders are affecting tubules. So, broadly, renal disorders we can classify as glomerular disorders and tubular disorders. How are we classifying them? We are classifying them as glomerular disorders and tubular disorders. So what comes under glomerular disorders? So can you name the diseases that we have listed as glomerular disorders? So this is the first set of disorders. We are going to call them as glomerular disorders. So among the list that we made, let us identify what all are glomerular disorders. Post-streptococcal glomerulonephritis. This is a glomerular disorder. Minimal chain disease is also a glomerular disorder. FSGS is also a glomerular disorder. Membranous nephropathy, MPGN, RBCN, these are all glomerular disorders. These are all glomerular disorders. Okay, so from PSGN to RPGN that I have listed here, these are glomerular disorders. So they have a typical way of presentation. So if I identify that pattern of presentation, I know that this is a glomerular disease. So similarly, this Bartter syndrome, Gitelman syndrome, then Liddle syndrome, Fanconi syndrome, acute tubular necrosis, these are all tubular disorders. These are affecting some or all part of the tubules. These are tubular disorders. Okay, so broadly now we know that when it comes to kidneys, some diseases affect glomeruli, some affect tubules. So your Bartter syndrome, Gentleman syndrome, acute tubular necrosis, Fanconi syndrome, they are all affecting the tubules, either whole of the tubule or some part. For example, Fanconi syndrome that we listed is affecting the proximal convoluted tubule. Gentleman syndrome is affecting distal convoluted tubule. Okay, so there are different channels which are getting targeted by those disorders. So is it clear that we can broadly localize the renal disorders to either glomeruli or tubules? But there is one more structure that is left out. What is that? Do you think all these nephrons are freely circulating inside the kidney? No, they're held in a place. Who is holding them in a place? The connective tissue. So around this nephron and the other adjacent nephrons, there is a connective tissue that can also get affected by the disorders. And when connective tissue gets affected, we will call it as interstitial nephritis. So interstitial nephritis is affecting the connective tissue of the kidney. So these are the disorders which are affecting connective tissue. So these are renal connective tissue disorders. Renal connective tissue disorders. Now let us see how these individual diseases present. So first we will begin with the glomerular disorders. So these glomerular disorders have two kinds of standard presentation. Two standard presentations. One of them we will call it as nephrotic syndrome. The other one we will call it as nephritic syndrome. So whenever glomeruli get damaged, they either present as nephritic syndrome or nephrotic syndrome. So what is the difference between the two? Can anybody tell me? What is the difference between the nephritic and nephrotic syndrome? They have some standard set of symptoms. And the main differentiating feature is the amount of protein that we lose. So normally from the glomeruli, only very low molecular weight protein get filtered out. And those proteins are called as Tom-Horsfall protein. Tom-Horsfall protein. The large molecular weight proteins like albumin and other proteins are not lost through the glomeruli. But when the glomeruli get inflamed or injured, we start losing protein into the glomerular filtrate, apart from this usual Tom-Horsfall protein. The quantity of protein loss depends on the structural injury to the glomeruli. When the injury is more, we lose large molecular weight and large amount of protein, then we end up with nephrotic syndrome. If I'm losing very small amount of protein, I end up with nephritic syndrome. So nephrotic syndrome is characterized by high amount of proteinuria. So the first feature of nephrotic syndrome is proteinuria, or losing protein more than 3.5 grams per day. If it is expressed as the urine protein creat ratio, then losing more than 3.5 gram of protein for every gram of creatinine lost in urine. For now, we will just keep it simple. Losing more than 3.5 grams of protein per day puts you in the bracket of nephrotic syndrome. So in the nephritic syndrome also I will have proteinuria, but we will call that proteinuria as subnephrotic range. The loss of protein will be less than 3.5 grams per day. So here also we will have proteinuria, but this loss of protein is going to be less than 3.5 grams per day. So this is also called as subnephrotic range proteinuria. This 3.5 gram plus per day is called as nephrotic range proteinuria. Second, glomerular injury often leads to development of hypertension, which can be encountered in both nephrotic as well as nephritic syndrome. The third thing, in patients with nephritic syndrome, we get minimal edema, which is mainly periorbital region. We will have periorbital edema. But on the other hand, when I'm losing too much of protein, right, my serum albumin levels decrease. And when my serum albumin's level decrease, you know that the albumin is the main determinant of oncotic pressure. So I'm losing my oncotic pressure. And when I lose my oncotic pressure, the force that wants to retain the fluid inside the blood vessel is lost. So I start losing the fluid into the third spaces, and I will develop not just the periorbital edema, but edema and fluid seepage in multiple tissues and third spaces. And when there is such diffuse edema, like pedal edema, periorbital edema, pleural effusion, ascites, pericardial effusion, all of this, we will call it as generalized edema or anasarca. So patients with nephrotic syndrome often present with anasarca. Anasarca is not usually encountered in nephritic syndrome. You will notice early morning periorbital edema. Okay. Then in these patients, nephrotic syndrome, when I check their serum albumin, they will have low albumin because albumin is being lost daily in the protein. The rate of albumin synthesis by liver falls short of the rate of loss of protein. I'm losing so much protein per day. The liver is not able to cope up. It is not able to produce that much albumin per day. So my serum albumin levels drop. We end up with hypoalbuminemia. Hypoalbuminemia. In nephritic, because the protein loss is not that much, the serum albumin level will be maintained in the normal range. Another finding we can notice in the nephrotic syndrome is they often have dyslipidemia. So their lipid parameters in the blood are altered. So these are the standard features that we get in a patient with nephrotic syndrome. What are these? Proteinuria, hypertension, anasarca, hypoalbuminemia, and dyslipidemia. Apart from that, these people are also losing the coagulation factors and they may be prone for developing thrombosis. So this is a prothrombotic state. It's a prothrombotic state. They're losing the antithrombin 3, all these substances, protein C, protein S, and because of that, they are prone for developing clots. So it's a prothrombotic state. Now, in nephritic syndrome, we have proteinuria, which is minimal. We have hypertension and periorbital edema, but there is something which is more striking. So in nephritic syndrome, the inflammation of the glomeruli make you lose RBCs into the glomerular filtrate. So you will end up with hematuria, which is not always encountered in nephrotic syndrome. So in nephritic syndrome, frequently you will have hematuria. Now my question is, hematuria can happen because of glomerular injury, as in case of nephritic syndrome. But hematuria can also happen if I have a renal calculi, or if I have a ureteric calculi, if I have cystitis, bladder infection, or bladder inflammation, or like some drugs like cyclophosphamide, which causes hemorrhagic cystitis, or if I have urethral injury, that could be even iatrogenic. While an intern is trying to pass a catheter, he may cause urethral injury. In all these cases, I will have hematuria. How will I get to know that this hematuria is because of the glomerular injury? So glomerular hematuria has certain characteristics. What is that characteristic? Whenever hematuria happens because of glomerular injury, the RBCs are passing through these glomeruli, injured glomerular capillaries. So when they pass through, they lose their shape, they become dysmorphic. But if I cause urethral injury, or if I cause bladder injury, and because of that I'm losing blood, I will be losing proper RBCs. So they won't be dysmorphic. They are not having abnormal shape. But RBCs which are passing through the injured glomeruli, they lose out shape, they become dysmorphic. So glomerular hematuria is characterized by dysmorphic RBCs. Hematuria with dysmorphic RBCs, and this is considered as the hallmark of glomerular hematuria. Dysmorphic RBCs are considered as the hallmark of glomerular hematuria. This is a potential MCQ and also a clue whenever an MCQ says that this patient has got dysmorphic RBCs on urine analysis. Examiner is directly telling that there is glomerular injury, this is glomerular hematuria. Please think about nephritic syndrome. Please think about nephritic syndrome. He is giving you the potential clues. What other findings I get in a nephritic syndrome? These RBCs which are leaking out into the filtrate, okay, they get impregnated. So normally what happens is the Tom Horsfall protein that normally gets filtered into the filtrate, that sometimes forms an aggregate. It settles in the tubules and forms an aggregate, and that Tom Horsfall aggregate is called as a cast. Means in the tubules, these Tom Horsfall protein molecules settle down to form a cast. This cast, the normal cast, which is formed by normal Tom Horsfall protein, is called as hyaline cast, which is normal. In your, my, or anybody's urine, you may end up seeing some hyaline cast, which are formed of Tom Horsfall proteins. Now these RBCs that are being filtered, they also go and get impregnated on this normally formed Tom Horsfall protein. Now I have a cast which has a sheet of Tom Horsfall protein which is perfectly normal, but on top of that RBCs are impregnated. Now what should I call this cast as? We will call this cast as the RBC cast. This will be called as RBC cast. So apart from this hematuria, we will also get red blood cell cast, which is again typical of glomerular injury. So these features are typically encountered when I have nephritic syndrome. So is it very difficult for us to differentiate between nephritic and nephrotic syndrome? No. What points are going to help us to differentiate? In nephrotic, we have nephrotic range proteinuria. In nephritic, we have nephritic range proteinuria, less than 3.5 grams per day. We barely reach 1 gram per day. It's usually less than that. Plus, you have this classical hematuria with dysmorphic RBCs, which is a very potential important clue for nephritic syndrome. Along with that, you have RBC cast. On the other hand, having hypoalbuminemia, anasarca, and dyslipidemia are pointers towards nephrotic syndrome. Now, some of you may be wondering, sir, why are you talking about so much between nephrotic and nephritic syndrome? There's a reason. If you can recognize that this patient has nephrotic and this patient has nephritic syndrome, rest of the diagnosis becomes easier. How? We made a list of diseases, right? So out of these glomerular disorders that we mentioned, some of them present with nephritic syndrome, some of them present with nephrotic syndrome. So by the time I recognize the pattern, I already have ruled out the other causes. For example, the post-streptococcal glomerulonephritis. This is a glomerular disorder. This usually presents as nephritic syndrome. So should I think of post-streptococcal glomerulonephritis in a patient who presented with hypoalbuminemia, generalized anasarca, dyslipidemia, and urine protein 3.5 grams or higher per day? No. Unlikely that PSGN would present with nephrotic syndrome. On the other hand, FSGS, which is very common in HIV individuals and African blacks, these patients typically present with nephrotic syndrome. So if someone presents with hypertension, periorbital edema, hematuria, dysmorphic RBCs, should I think of FSGS? Unlikely, right? The membranous nephropathy also presents with nephrotic syndrome. MPGN can present with nephrotic syndrome. RPGN presents with nephritic syndrome. PSGN presents with nephritic syndrome. So by knowing this pattern of presentation, we will be able to rule in or rule out diseases. So what are the diseases that present with nephritic syndrome? So let us list the important diseases that present with nephritic syndrome. The first one, examiner's favorite, which is post-streptococcal glomerulonephritis, which is also called as post-infectious glomerulonephritis. Okay. The second one, where again the nephritic syndrome occurs after a throat infection, it is called as IgA nephropathy. IgA nephropathy. The third one is called as Henoch-Schönlein purpura, HS purpura or Henoch-Schönlein purpura. The fourth one, RPGN. These can present as nephritic syndrome. Now, what disorders can present as nephrotic syndrome? The first thing that should come to your mind, which is typically more common, in fact, the most common cause for nephrotic syndrome in children, that is minimal change disease or MCD. Minimal change disease or MCD is the most common cause for nephrotic syndrome in children. Apart from that, the focal segmental glomerulosclerosis, which is usually encountered in HIV individuals or the African blacks. In HIV people, it is also called as HIVAN, HIV associated nephropathy, FSGS. Then membranous nephropathy, then membranoproliferative glomerulonephritis or MPGN. So these are the disorders that usually present as nephrotic syndrome. So if I can recognize nephrotic versus nephritic, I can rule in or rule out these disorders. Further, how do we make a diagnosis? We will discuss later as we will have one class on nephritic syndromes. We will have one class on the nephrotic syndrome. We will learn further approach. Just to give you a hint. For example, if there is a patient who presented with Hematuria, proteinuria, hypertension, periorbital edema, RBC cast, and dysmorphic RBCs after sore throat, and usually from sore throat to the development of these symptoms, if it occurs after 1 week, we think of PSGN. Okay, let me write it down. Let us say I had a sore throat, and after that, more than 1 week or 7 days later, I presented with nephritic syndrome, that is hematuria, dysmorphic RBCs, hypertension, all of that. It is highly suggestive of post-streptococcal glomerulonephritis or post-infectious glomerulonephritis. I can have a very similar presentation, but I develop sore throat and then I develop nephritic syndrome. But this nephritic syndrome occurs within 3 days of the onset of sore throat. Then it is highly suggestive of what we call as IgA nephropathy. IgA nephropathy. So we'll always have such history clues to quickly recognize the pattern and come out with the clinical diagnosis. Further confirmation, of course, with laboratory investigation or renal biopsy. Okay. Similarly, if a child presents with nephrotic syndrome, by all means, majority of the cases, the diagnosis will be minimal change disease. If an adult presents, it could be most likely membranous nephropathy or FSGS. Again, if it is membranous nephropathy can happen as primary membranous nephropathy or secondary. Secondary is more common in hepatitis B patients, sometimes rarely in hepatitis C patients. And in primary membranous nephropathy, it is due to an antibody against phospholipase A2 receptor. So if I recognize this antibody, like let us say I got a patient with nephrotic syndrome who is adult, where minimal change disease is quite less likely, right? So I will get this hepatitis B, hepatitis C panel done and anti-phospholipase A2 receptor antibody done. If this antibody comes positive, I have my diagnosis. Patient presented with nephrotic anti-PLA2 receptor antibody positive, it is membranous nephropathy. Okay, this antibody is negative, but hepatitis B surface antigen is positive, pointing towards membranous nephropathy. Maybe if required, I can confirm with renal biopsy. If I get an HIV positive individual, then it could be HIV associated nephropathy. If he has presented with nephrotic syndrome, I would be thinking about FSGS. Confirmation with renal biopsy. But clinical suspicion close to diagnosis is possible if I'm able to recognize the patterns, right? So that's about our approach to glomerular disorders. Now, what about the tubular disorders? How a patient of tubular disease presents. So all these glomerular disorders present with either nephritic or nephrotic syndrome. Tubular disorders. Remember, what is the function of tubules? Simple words. Function of glomeruli is to filter, create a filtrate, what we call as glomerular filtrate. The function of tubules is to reabsorb. So when these tubules get damaged, the reabsorption gets impaired. Like for example, if I cause damage to proximal convoluted tubule and I fail to reabsorb the stuff that is reabsorbed in the proximal convoluted tubule. Like in the proximal convoluted tubule, we reabsorb glucose through SGLT2. We reabsorb amino acids. We reabsorb 80% of the water from the filtrate. So if I cause damage to this proximal convoluted tubule, I will not be able to reabsorb amino acids. I will lose amino acids in the urine. I will have amino aciduria. I will lose glucose in the urine. I will have glucoseuria. I will also lose a lot of water in the urine. What we call as when we are losing excess amount of water in the urine, we will call it as polyuria. So polyuria and loss of electrolytes. Like for example, we reabsorb sodium in the proximal convoluted tubule, in the thick ascending limb of loop of Henle, in distal convoluted tubule. So if I have damaged any of these structures, I may not be able to reabsorb sodium. I will lose sodium in urine. So I will have either polyuria or amino aciduria, glucoseuria, or loss of electrolytes, or in simple words, electrolyte imbalance. So if I have a patient with electrolyte imbalance, glucoseuria, amino aciduria, or polyuria, it is pointing towards a tubular disorder. Tubular disorder. Now, individually, we can recognize if I have excess sodium or excess loss of sodium, excess potassium in blood, or excess loss of potassium. We can localize which structure is being affected. That we will discuss when we take up the tubular disorders. So now we have a fair idea about the glomerular disorders. Let us also list what manifestations tubular disorders may present with. So tubular disorders may present with, number 1, polyuria. Polyuria. Now, when do you call it as polyuria? That's the only question that I need to sort. Apart from that, these patients may have amino aciduria, that is typical of PCT lesion, that is seen in Fanconi syndrome. These patients may have glucoseuria. I don't say that all of these features will be present in a given patient, but in case of nephrotic syndrome, the features that we listed are typically encountered. In nephritic syndrome, the features that we listed are typically encountered. Depending on which part of the tubule is affected, some of these features will be present, not all of them. Okay. Polyuria, aminoaciduria, glucoseuria. Then we can have acid-base abnormality and electrolyte abnormalities. Electrolyte abnormalities and acid-base abnormalities. Like you might have heard about renal tubular acidosis. The name itself says the problem is in the tubules. So acid-base abnormalities and electrolyte abnormalities. Not exactly 2 liters, because the urine output is not fixed for all. It depends on your body weight. So when you're losing more than or equal to 40 ml per kg per day, then we call it as polyuria. So let us take an example of a 50 kg individual, 50 kg person. Then when do you say he has got polyuria? For a 50 kg person, 50 into 40, that becomes 2000. So if he is losing more than 2 liters per day, then we will call it as polyuria. But for a 60 kg person, it is 2.4 liters. So the number depends on the body weight. So then for him, polyuria refers to urine output more than or equal to 40 into 50, that is more than or equal to 2000 ml per day. Then we will call it as polyuria. So tubular injury can manifest as polyuria. So this is a pattern of tubular disorder. This is how the tubular disorders present. Okay. Apart from that, the tubular injury may have another clue. What is that clue? Classically encountered when there is acute tubular necrosis. So in tubular disorders, these are all targeting selected channels. You will have selected manifestation. But acute tubular necrosis, the tubules get necrosed. It's not selective. Like, okay, only PCT will get necrosed, or only DCT will get necrosed, or only thick ascending limb of loop of Henle will get necrosed. So it affects different segments. And one of the common features that we will get in acute tubular necrosis, of course, yes, we will have polyuria. Apart from that, what else we will have? When these tubular cells, these tubules also have cells, right? Epithelial cells. When they get shed, those epithelial cells, because there is formation of the so-called hyaline casts, when these epithelial cells get shed, these epithelial cells which are shed, they will also get impregnated on the tomorsal protein sheet or hyaline cast, and now this cast become what is called as renal tubular epithelial cell cast. It is called as renal tubular epithelial cell cast, typically encountered in acute tubular necrosis. So another finding that we may get when the tubules are the site of damage is renal tubular epithelial cell casts. And these renal tubular epithelial cell casts, renal tubular epithelial cell cast, if I make this cast stay longer, these cells will go through apoptosis and release a pigment called as lipofuscin. And once that is released, this cast will start getting a brown pigmentation. And then in that case, we will call these casts as muddy brown cast. It's the same cast, renal tubular epithelial cell cast. If the cells are fresh, it is RTEC cast. If the cells disintegrate, leaving lipofuscin, giving the brown pigmentation, we will call it as muddy brown cast. So you may encounter muddy brown cast. If there is a tubule which is site of damage, you will encounter muddy brown cast. Okay, so now whatever features we have mentioned, we can further zero down. Like if I have amino aciduria or glucoseuria, it is pointing towards generally encountered in Fanconi syndrome. Apart from other causes like diabetes, we can have hyperglycemia and hyperfiltration related glucoseuria. But if there is no diabetes, you still have glucoseuria. One of the possibilities is that PCT is dysfunctional and you have Fanconi syndrome. Electrolyte abnormalities are encountered in all these syndromes that we mentioned, where selected channels are targeted, like Barter, Gitelman, Liddles, right? Liddles, Barter, Gitelman. Then acid-base abnormalities. Apart from your other causes for acid-base abnormalities, you can have renal tubules selectively having dysfunction of either the acid excretion or bicarbonate reabsorption. In that case, we will call it as renal tubular acidosis. And these RTEC cast and muddy brown cast are usually pointing towards acute tubular necrosis. Okay, so these are all features of tubular disorders. So is it possible from a story, lab investigation, symptoms for us to either localize it to glomeruli or tubules? Yes, if glomeruli are affected, patient will have the nephrotic or nephritic presentation. If tubules are affected, these are the features that patient is going to present with. He may have polyuria, amino aciduria, glucoseuria, electrolyte abnormalities, acid-base abnormalities, or these abnormal casts. Now, what is pending in this whole list of disorders? The interstitial nephritis. So when the interstitium gets affected, how the patients will present? Remember, the most common cause for interstitial nephritis is the drug allergy. And among the drug allergies, the most common allergy is allergy to antibiotics. And among the antibiotics, the most common allergy which causes interstitial nephritis is allergies to beta-lactam antibiotics, like the penicillin and other beta-lactam groups, including cephalosporins. So how will they present? Patients often have already the allergic rash, along with that renal dysfunction. And whenever allergy comes to mind, which cells should come to our mind? The eosinophils. So here the kidneys, interstitium or connective tissue is infiltrated by eosinophils, because whatever drug we are allergic to is also filtered in the glomerular filtrate. And wherever that allergic substance is there, the inflammatory response is mounted by the body. That's why the interstitium is getting targeted. Okay. Now these eosinophils that are infiltrating the interstitium, they may find its way into the urine. So we will have eosinophil urea. Eosinophil urea. So that's again a potential clue for the interstitial nephritis. So how do I recognize that this particular patient may be having interstitial nephritis? The patient may have the drug rash. First thing, that is a potential clue. So if there is interstitial nephritis, patients may have the most common cause for interstitial nephritis is drug allergies. Among them, the most common drug class responsible for interstitial nephritis is beta-lactam antibiotics. So these patients may have drug-induced rash. Second, these patients will often have eosinophilia. The eosinophil count in the blood is high, and then eosinophils may find its way in the urine. Normally, we don't encounter eosinophils in the urine, but you may have eosinophil urea. Eosinophil urea. This is an important MCQ clue. Any MCQ which is talking about eosinophils in the urine, examiner is indirectly pointing towards interstitial nephritis. Interstitial nephritis. So broadly speaking, this is how we will have a fair idea which structure in the nephron is being targeted by a particular disease, right? So let me summarize quickly what we have learned today, and then in the next class we will start with the nephritic syndrome, then we will go to the nephrotic. So that completes our glomerular disorders. Then we will take up the tubular. In the tubular we will discuss all these channel targeted syndromes as well as the acute tubular necrosis, and then finally we will take a class on the interstitial nephritis, and after that we will come to the two main topics, that is acute kidney injury and CKD and its complications, right? So let me summarize what we have discussed today. We have listed the diseases that affect the kidney, and then we learned that these diseases can be localized. Some diseases are affecting glomeruli, some are affecting tubules, some are affecting the connective tissue. Glomerular disorders, we will call them as glomerular disorders. Tubular disorders and connective tissue disorders can be called as the interstitial diseases, and if there is acute inflammation, we will call it as interstitial nephritis. Now these patients, glomerular disorders, they either present as nephritic syndrome or nephrotic syndrome. Tubular disorders patients can present with polyuria and loss of filtered substances in the urine. It could be glucose, amino acids, electrolytes, right? So that can result in electrolyte imbalance, polyuria, amino aciduria, glucoseuria, and the acid-base abnormalities. And interstitial nephritis usually presents with abnormal renal function test. Along with that, because drugs are the leading cause, patients often have drug rash and eosinophils in the urine, right? So this is the basic initial point that we need to know for the understanding of all the renal disorders. So with that, I conclude the today's session. In the next class, we will start with the glomerular disorders. The first class will be on the nephritic syndrome. So if you want, you can go through some pathology MCQs on these topics, and then we will learn the clinical aspects about it in the next class. So that's it from me today. I'll see you in the next class. Till then, have a good time. See you. Bye-bye. Yeah, the notes will be made available on the Physics Wala Meded Telegram channel, and it should be available in a couple of hours for you. See you guys. Bye-bye. Study well.